Hi, everybody. Welcome back to episode two with Celtic Consulting and EpiCompliance together as a partnership. And I am going to be talking about, again, some F tags today, but I'm going to be talking about the F tags that get us into an IJ level, immediate jeopardy level. And at the end, we're going to share a really cool tool. It's a huddle tool that helps us with, at-risk meetings, if that's what you want to call them, or huddle meetings for five-star quality measures at the end, where that can help you improve and give you a script to make sure we're talking about everything about the resident. So Tyler is going to put up the slides. I'm going to go off video because it's extremely distracting. And we're going to
Perfect. Thanks, Robin, for that little intro. Like she said, part one, was a lot of focus on survey related matters. Today, we're going to dive into the clinical pillar. So, care plans, infection control, quality measures, and all that kind of stuff. I said this last time. I know there's a lot of people that have been in here from the first webinar. A lot of you guys, maybe this is your first one. So you might be saying, who in the world is this guy and why is he on camera? And as I said last time, that's a fair question. So my name is Tyler Wright. I'm a director at a company called EpiCompliance, and we've partnered with Celtic over the years on a number of different projects. One being a skilled nursing facility specific compliance software, which we'd love to get your feedback on towards the end of this. But today, of course, we're going to focus on a couple of different things, right? Our goal, Robin will be coming on here in a second, and our focus is really in this webinar series. It's free. And it's focused on just how can we provide value in all of the main areas of your job, whether you're an administrator, a DON, you own, part of ownership or leadership, or anyone all the way from a CNA to a DOR and everywhere in between. So our goal today is provide tangible value. We're going to give you guys some free tools and things that basically will take what we've gone over and say, how can we put this into action? And then, of course, we'll have a Q&A at the end with Robin, and we'd love to get your feedback on a few things as well if you guys have an extra 5 minutes or so. So, to the woman
scroll that through, Tyler. Everybody knows me. Scroll.
to the
Please.
woman that needs no introduction, Robin Sweeney. You can see all the stats there, but a great speaker, even better person, and I know she's excited to get into it. So I'll let her take over. So what I'll do is I'll have to turn my camera off, and then we'll have her turn hers on.
Perfect. I'm not turning on. I'm staying this way, but thank you.
Okay, perfect.
All right, we're going to go right into F656 care plans. Now, I'm going to tell you when I do speak about care plans, one of my things that I don't love about talking about care plans is because one nurse to another nurse to even me, we're all going to care plan totally differently. But I'm not talking about how to do an individualized care plan today. We're going to talk about the F tag and what it's, how it specifies what's the intent of the law of F656. So what makes a care plan person-centered? So a care plan reflects who the resident is, not just a diagnosis list. So it has to reflect the resident's preferences, routines, cultural identity, contains measurable goals with numbers, frequency, and observable outcomes. It needs to be co-created with the resident and or the resident representative. And we need to have specific individualized interventions, not generic EMR copy and paste. So the care plan itself needs to be a living, fluid document. It needs to be able to truly reflect the care that we're providing to the resident. And if it doesn't, it could put you in jeopardy of a survey tag, especially F656. Next slide, Tyler. So I just put this little slide in here because everybody asks me about goals. What are measurable goals? What's a compliant goal versus not compliant goal? So when I used to sit behind the chair and do MDSs, you're crushed for time. You might have 5 or 6 admissions to do in a day, get a comprehensive set of care plans done. And it does take a lot of time to do it. And sometimes I'm guilty of it too, picking the generic one from the EMR, which is fine as long as you then, personalize it a bit. So what's a compliant goal? Say something like the resident consumes 75% of more of their meals, 5 to 7 days per intake documentation. I would never write 7 days because obviously if you're non-compliant for one of them, you're not making your goal. transfer with one person assist using a gait belt, 3 times daily. That is a measurable goal. A pain score of 3 or less, or, within 30 minutes of the PRN pain medication. For activities, participates in one or more preferred social activity per week, or if the resident doesn't want to attend group activities, that he has a one-on-one visit with the recreation staff at least 1 to 2 times a week. Because there are people in your building. I mean, I don't know if you've noticed, I've noticed just auditing throughout the country, the ages in some SNFs because of substance abuse disorder is getting younger and younger and younger. And these 30 and 40-year-olds don't want to play bingo, right? So you have to come up with what are we going to do for a younger crowd's socialization in a SNF. What would be non-compliant? What would put you at risk for survey? Saying something like improve nutritional intake with no quantity, no frequency, no goal. Assist with transfers as needed with no assist level, no time frame. Now, granted, if you write assist with transfers as needed, if I'm a surveyor, I'm going to go back into the orders to see what the transfer order for that resident actually is. You're making them do a little bit more work, but you can find the answer by looking at the orders. Monitor for pain and medicate with no measurable outcome. Encourage socialization with no type and no individualized type of socialization. So those are the things that you want to, think about when you're doing your goals in your care plans. And when I review care plans, I see some people who need to pick 10 goals. You do not need to pick 10 goals. One measurable goal for each problem is totally fine, because the more goals you write, the more issues you might have about making those goals. So I'm a more on this one, a less is more person. If you knew me in real life, more is more, but on care plans, less is more. Go ahead, Tyler. So just a quick little box on care plan deadlines. I'm up in Connecticut, so I audit in person, mostly in Connecticut, and we have been seeing the Connecticut surveyors, tag on this. We have brand new surveyors because nobody stays in this job. So every round, every year, it seems like we get a new bunch, and they tag, low hanging fruit. So what are the care plan deadlines? So baseline care plan needs to be initiated and completed within 48 hours of admission. I actually just taught this yesterday. So it doesn't say in the regulations how it needs to be done. It just needs to be done. For those of you who do it electronically on your EMR, it's a beautiful thing, but also remember it's time stamped. So if somebody comes in on Friday night at 5 o'clock, usually your staffing is a little bit different on the weekend. Technically, to be in compliance with the baseline care plan, it needs to be done Sunday night by 5 o'clock. Is that happening in your building? I have other buildings who use the baseline care plan on paper. So it could be passed around the room at morning report the next morning, where you have the whole interdisciplinary team and everybody can fill in their part of the baseline care plan to be compliant. And then by day 21, the comprehensive MDS assessment needs to be completed. So this starts the 7-day clock. Where's my comprehensive care plan meeting there? So, just to circle back on that, the comprehensive MDS needs to be completed by day 14, and then you have 7 days after day 14 to complete the comprehensive set of care plans. And then usually 7 days after that, you have to have your care plan meeting. So that's where your full IDT team comes. That's where your baseline care plans stops being active. Your baseline care plan stops being active as soon as your comprehensive set is done. When you have that care plan meeting, you should have the resident or the resident's representative sign the baseline care plan and give a copy to the family. So now your comprehensive set is in play. And then they should be reviewed every quarterly after each MDS, and obviously with every significant change. So if you're not doing your care plan reviews quarterly, you need to. It depends on what type of EMR you have. I'm a PCC person, as some of you know. There is a button in PCC that does say next review, and then it helps you timestamp that you reviewed the care plans on a quarterly basis, because some of you might not even have a care plan to change. So how do we prove that the care plan was reviewed? Like I said, in PCC, we have the new review button. If you don't have that system, maybe you would do the, make a note in the progress note saying that the care plan reviewed. And I do see a note that from Patricia, that we usually do the comprehensive care plan meeting shortly after the MDS is completed, but I was not aware of the 28-day deadline Yes. So everything in the MDS world has a deadline, and we always say 3 weeks. When somebody comes in, typically how we do it, Patricia, is when somebody comes in, we will put them on the care plan list because we have a month out and the month forward. We'll put them on the list and we'll mail them a deadline. And then Christine said, I believe the signature requirement is per facility policy or state requirement. It's not actually mentioned in the state operation regs. For the baseline care plan, it is mentioned in the regs, and I can send it to Tyler and we can send that to you, Christine. Okay, next slide, Tyler, please. So the IDT rules and top deficiencies. So who are the required IDT members? The attending physician. No, he's not going to come to your baseline care plan meeting. But he is a required meeting. That means he oversees the whole processes in your buildings. He approves orders and the care goals. Registered nurses, so they lead the clinical assessment and coordination. It would be lovely if they attended, but they have to have some input into the care plan meeting. CNAs, direct care, meaning the ADLs, the behaviors, they know the preferences. Now, does a CNA attend your care plan meeting? That would absolutely be beautiful if they did, but obviously they can't because CNA staffing is usually a challenge. So what I have told people to do in the past is make a copy of the CNA care card, whether you do it still on paper or whether you do it electronically. Give it to the CNAs either the day before the care plan meeting or the morning. Say, can you please read this care card? Is this the care we're still providing to Fred? And please sign it. And then I upload it into the EMR so you can show that you had CNA input without actually having the CNA attend the meeting. And if we aren't doing something that's on the care card or the care plan, then we need to address it with that certain IDT team, maybe rehab, the transfers are different, and we need to take care of that. Dietary and social services, nutrition and psychosocial needs. I know some people, small buildings especially, only have a dietitian in a building 1 day a week. That's hard for them to attend the care plan meeting. So we get their input. We may ask, do I have any weight loss? Do they have any dietary preferences? Social services is also somebody who should be at your care plan meeting. It's usually social service, the MDS nurse, and hopefully a nurse that takes care of that resident on the floor. But the more people that you have attending the meeting, we should have a signature sheet showing that that meeting took place, who attended from the facility, and who attended from the resident side. So what are the top survey deficiencies? The care plan is not updated after a fall or significant weight loss. If we have a generic copy and paste from EMR interventions with no individualization, if the goals are vague, meaning to improve, you can use the word improve, but you have to give, improve what? We'll be able to walk, 150 feet by the next quarterly meeting. We need to what are we maintaining? If we write maintain, or what are we monitoring? And the resident is not if the resident's not invited to the conference and no documentation of why. Because some people and some families don't want to have, come to the conference, and that's totally fine. But that doesn't mean that we don't have it. We still have to have it, and we still have to document it. Go ahead, Tyler. Okay, so before I get into F880 infection control, I do have the state operation manual open, Appendix PP, which Tyler will show you where it lives on Epi. But I just wanted to give you a couple of examples of care plans deficiencies that will get you in an IJ, so immediate jeopardy. So this is harm or actual harm or potential harm. So if a resident has a known history of inappropriate sexual behaviors and aggression, but the comprehensive care plan did not address the resident's inappropriate sexual behaviors or aggression, which placed the resident or other residents in the facility at risk for serious physical or psychosocial injury or harm, impairment, or death. So those all have to be care planned. Another potential IJ. The facility failed to implement care plan interventions to monitor a resident with a known history of elopement attempts, which resulted in the resident leaving the building unsupervised, putting the resident at risk for serious injury or death. And I think we talked about this on the first webinar when I did go down to a PAC-in March, and Evan Schulman, who's the head of CMS Nursing Home Survey and CERT, talked about the most frequent IJs in the United States so far. Elopement was number one. I did not guess elopement, but elopement, he had said, is number one. So obviously that's an issue. Here is the other example they give us in the state operation manual for IJ. The facility failed to identify the resident's cultural dietary restrictions related to eating pork. After dinner, upon realization that she had eaten pork, the resident began crying inconsolably and screaming that this was explicitly forbidding in her culture and the faith of Islam. The resident remained tearful and inconsolable for days and would not eat the food provided by the facility, which resulted in weight loss and serious psychosocial harm. So, as you can see, these are levels of IJ in the state operation manuals. It gives you examples at all levels. So we want to make sure that, we have these. So now we're going to move on to F880, which we did cover in the first webinar, but this is such a big part of our world, infection control. So what are the 7 required infection control components? And your written program must address all 7, and you can find this in this subsection of the Code of Federal Regulations. The State Operation Manual, F880, has the most pages in the State Operation Manual. It's more towards the end because for some unknown reason, when you print the State Operation Manual, the pages are not numbered. So, all right. So 1, surveillance. Active monitoring and tracking of infections of all residents. We have to have surveillance. We have to have policies and procedures, meaning we have to know what standard precautions are, hand hygiene, isolation, employee health, antibiotic stewardship, protocols and activities monitoring, to reduce unnecessary prescribing. Do we have evidence-based criteria? Are you using it, whether it be McGear's, Loeb, NHSN? And if you are doing it, where does it live? Does it live in a notebook in your office? It needs to live somewhere. The 4th one, incident reporting. Document all infections identified and corrective actions taken. Immunizations, flu, COVID-19, and pneumococcal vaccines. And if the resident or the resident's family declined, you need to keep all that information. Staff training, initial ongoing training with documented completion records. And then number 7 is outbreak reporting. 2 or more similar cases in 72 hours is a reportable outbreak. I do see somebody raising their hand. Do you want to type it in the chat if you have a question? Or I don't know if you can unmute yourself. Oh, mistake. Okay, perfect. All right, Tyler, next slide. So this is basic, my friends. Standard versus transmission-based precautions. What are standard precautions? All residents, all the time. Hand hygiene before and after every resident contact. And I'm going to read you when we're done talking about infection control, how you get an IJ here. Gloves for blood, bodily fluids, or non-intact skin. Gown when your clothing may contact bodily fluids. Mask and eye protection when splashing is anticipated. Okay, so transmission-based. One infection is suspected for contact, like MRSA, C. diff, gowns and gloves, dedicated equipment. For droplet, flu, RSV, COVID, surgical mask within 3 feet. Private room, depending on who the cohort is. Airborne, TB, measles, fit tested N95 if you had a negative pressure room, and all types, obviously near door signage and resident education required. And don't forget about, which is not on here, enhanced barrier precautions. So anybody who has an open wound, any ostomies, any histories of an MDRO, we're going to use also enhanced barrier precautions. Next slide, Tyler. So hand hygiene and PPE. Surveyors score every observed hand hygiene and PPE opportunity. They're watching this. They're watching this in the halls. And one of my big pet peeves is when I used to do some VP of clinical operations stuff. Oh my God, gloves in the hall. That's like my trigger. No gloves in the hall. So that is, a huge infection control risk. So hand hygiene, before and after every resident contact, no exceptions. Before donning and removing gloves, every single time. And C. diff requires soap and water. Alcohol does not kill C. diff spores. And like I said on the last slide, go on the CDC website. They just updated the CDC guidance for isolation, so you might want to look at that. PPEs, check the door sign before entering any isolation room. Don before entry, doff at the doorway, never walk in the hall with used PPE. That will get you an IJ. Wrong PPE or improper techniques is an immediate F880 finding. And now, how do we get into an IJ level? So you can get it in a lot of different ways here. A new one just added to Appendix PP is the facility failed to ensure that its staff demonstrated proper use of gloves with hand hygiene between residents to prevent the spread of infection. The registered nurse was observed wearing gloves while providing direct care to a resident who was on contact precautions for an infection for an MDRO. The RN left the room after removing the gloves, but did not conduct hand hygiene, went to a second resident, and started providing direct care. As a result, the second resident was likely exposed through indirect contact transmission to the MDRO, creating the likelihood of serious injury, serious harm, serious impairment, or death. They aren't kidding about hand hygiene, my friends. So hand hygiene also should be on the staff development calendar. If you want to do it monthly, that would be great, but at least quarterly, because you have to remind everybody of hand hygiene. And I, unfortunately, in my buildings, got into an IJ this way, and I'm going to read to you what the IJ is. The facility failed to follow standard precautions during the performance of routine testing of blood glucose. The facility reused finger stick devices for more than one resident. The practice of reusing finger stick devices for more than one resident created an immediate jeopardy to resident health by potentially exposing residents who required blood glucose testing to the spread of blood-borne infections in the facility. So, if you're using the same glucometer, blood glucose meter between each resident, and you have a cleaning protocol with the certain types of wipes, there is a dwell time on the wipes. You need to make sure you're reading the wipes that you have and using them according to manufacturer's precautions. Most dwell times on the wipes are 2 minutes. 2 minutes doesn't sound a lot, but it does sound a lot when you're a nurse on the cart and you need to move down the hallway to do the next resident. It's blood sugar. So hopefully all your residents have their own glucometer, or if you do use shared ones, we will you have a policy and procedure, and you're paying attention to the dwell time. All right, Tyler, my friend, next slide. So what is our role in infection prevention? CNAs have the most resident contact and are the first line of defense. Hand hygiene every time, before entry, after glove removal, after toileting. Check the door sign before entering. Use the correct PPE for that room. Report any episodes of new diarrhea, vomiting, fever, respiratory symptoms immediately. Stay home when sick. Working with symptoms violates F880. Next slide, Tyler. Okay, so that's enough about F880. Now we're just going to very, very, very lightly touch on 5 stars, because this is a 6-hour conversation for me. So we're going to talk how this affects, your 5-star rating starts at the bedside. It starts with CNAs. CNAs document ADL, section GG, and I think I'm going to talk about this till I'm blue in my face. And yes, everybody on the line, nobody ever gets this right. With GG. It's a constant struggle with the CNAs to get it right. So it's constant teaching, constant training, but you can't give up. Then we have the MDS assessment. So the MDS coordinator codes observations and transmits as CMS by I-keys. Having a knowledgeable MDS on what's going to trigger, especially in section GG, is very important. Then obviously CMS calculates the data, runs the algorithms versus benchmarks, then the 5 stars updated. So our QM score is updated quarterly. It is due to be updated this July. It's usually the last Wednesday of the month. Your preview reports are out right now. So if you want to look at those for your updates that are going to come out in October, that would be very helpful. And then public and surveyor, families search scores, surveyors review before every survey. So it's super important that you're looking, especially at your preview reports, so that you could fix stuff that might be incorrect that will hurt you, because once it's out on the 5-star, you can't change it and everybody can see it. So an insight is poor documentation means maybe a miscoded MDS, inflated QM rates, and a lower 5-star rating. That's the importance of that. So that's when we talk about in a few minutes, the importance of a 5-star huddle. Next slide, Tyler. So here's some long stay versus short stay quality measures. Like I said, they're recalculated 4 times a year, due to recalculate at the end of July. Long stay measure, anybody in my building 101 days or more. And there's 7 measures. And these are MDS measures only. I didn't include the claims-based measures. So the antipsychotic medication use, which was updated in January 2026. If you don't know how that was updated, you need to find out. It's very interesting. It's not coming only from MDS coding anymore. It's MDS and claims-based, because they think, our MDS people are liars and cheaters, which is a sad statement. And so they're taking it from claims-based. Need for ADL help has increased. Falls with major injury, and I'm going to bet my house when the final rule comes out this August, that falls with major injury starting in October will also be a claims-based measure. It's going to be hybrid, just like antipsychotic. UTI infection rate, catheter left in bladder, and ability as walk has worsened, section GG, and residents with pressure ulcers. And the short stay measures, there's not a lot of them. So these are my people in the building less than 100 days or less. And there's only 3 MDS measures, and there are claims-based measures. So the discharge function score, which is GG based, that started in January of 25, and that plagues everybody because that uses a year's worth of data. So it uses a lot of data to come up with that score. Antipsychotic medication use and pressure ulcers that are new or worsened. Tyler, if you can switch for me. So section GG, this is so important for your quality measure scores. Accurate coding is the only defensible approach. It protects your score. So what it requires, the entire IDT completes it: nursing, PT, OT, CNA, ADL flow sheets. I actually taught a 3-hour class yesterday in Connecticut on defensible documentation, and section GG. When it's all over the place, it's totally fine that it's all over the place, because your resident can be different at all parts of the day. So that's why we want to make sure we're capturing at all parts of the day. If you're only having your CNAs answer GG, or you're only having therapy answer GG, you're doing your facility and the resident a disservice. Number one, we might not be getting the complete reimbursement we need. We're opening up our billing to a compliance tag. Am I missing a possible SIG change? Everybody needs to complete their GG. We need to gather all the documentation, and MDS, or as a huddle, or as a group of people, need to come up with accurate coding. And there's nothing wrong with interviewing the resident or the family, or observing the resident and the CNAs doing the section GG activities. And remember, it's coding the usual performance, not the most dependent or the most independent, because we're MDS coordinators and we like rules. And this is what bothers us on GG. There is no rule. It's like the usual. It's subjective. We don't do well with subjective. And I think that's a lot of people's problems. It must be completed at admission and discharge to enable comparisons. And then the most common coding errors that hurt your score. Coding the most dependent instead of the usual. It inflates apparent worsening. Not completing GG at discharge. You have to. You dash fill. For those of you who know me in Connecticut, how I teach it, you dash fill, I come kill you, because you're opening your building to a 2% annual payment reduction if you dash fill the MDS. They want the answers. You need to give them the answers. Overcoding dependence due to safety concerns and actual ability. Go ahead, Tyler, next slide. So what families and surveyors see on Care Compare? Your 5-star rating is public and permanent. You can't change it. QM stores, and every person, every family can see them. Surveyors obviously see them, so they already know who they're looking at before they come in. QM domain is refreshed quarterly, like we just talked about. And then make sure you look at your preview reports before your quality measures go public, and they're out now. So I would suggest looking at them, going through, seeing what you're triggered. If you're triggering, go look at that MDS to make sure that you coded it correct. And remember, falls with major injury stays on for almost a year. So if you think, oh yeah, Fred fell like 6 months ago, oh yep, Fred's going to haunt you for another 6 months. So you need to make sure that you understand all that. Next slide, Tyler. So we've done this. If you want to scan this QR code, we created Celtic and EpiCompliance, this 12-page long, it's long, my friends, this weekly quality measure huddle script. And it goes over things that are going to trigger on your quality, what questions you should be asking at your at-risk meeting. And if people are triggering, we can put them, there's places to put them on this script. So then you can make sure that you come back to them the next week, and keep making sure that the trigger measure is getting better or declining. So this is a really great tool. Hope that you enjoy it. I'm going to give you guys a minute before Tyler switches to scan the QR code.
Yeah,
If anybody,
I'll go ahead and put it in the chat as well. If for whatever reason somebody has an issue with the QR code, so I'll put that in the chat. That is to where to download that, and then also I know we had talked about. Let me see if I can. I don't want to stop shit. There we go. I can pull this up real quick, just kind
oh,
of
that
so
would be great, Tyler. Thank you.
you guys can see a little bit more. I'll kind of just. You guys can see this, right?
I can see it.
Okay. So,
So
so
you,
yeah, Robin can
yeah,
kind of
you
talk you
could,
through a little bit of this.
right. You could check your attendees, which I love, to prove compliance. You have all, this is just like how long it should take you, the resources that you should be bringing to a quality meeting. This is just some tips on an agenda and a flow. You can go a little faster through that, Tyler. But then, the resident level review framework. What are my prompting questions? So, there's some questions that we can be asking as an MDS coordinator, as a DNS, you know, especially looking for SIG changes. The state of Connecticut, they are killing us right and left with survey tags for GG decline because nobody's paying attention to them anymore because GG is documented all over the chart. From dependent to independent everywhere, it looks like the resident's declining, but they're not declining. We're not identifying it to put a note in the chart to be able to avert that tag. So we got to start paying attention to that. And then we're talking about falls, pressure ulcers, um, antipsychotic medication use, the hot button ticket. I put the regulatory updates in there that came out on January 26th, 2026. We're going to talk about weight loss. Everything's in here that you should be discussing. Just a little script, just some guidance to help you with your at-risk meetings or quality meetings, whatever you guys want to call them. And then you could, if you find issues that you need to deal with, you can put the actionable item there and then deal with it through the week or at the next meeting. So when's your urgent communication? I think it's a great little script. So hopefully that helps you guys. And that kind of brings us into where Epi would come into helping you with your compliance too. So do us a favor. If you've gotten value so far, this is episode 2 out of 6. We've got 4 more to go. Just let us know if this is giving you value, or if you want to see it a different way, here's something else. Let us know because we're open to it. And I appreciate it. Tyler and I both appreciate it. So thank you guys. I appreciate it. I really do. All right, Tyler, my friend, you got it from here.
Perfect. Well, yeah, so I'll go ahead and turn my camera on if I can figure out where it is. It tends to be a bit of a redundant question when we ask if you guys got value out of what Robin presented, because there's usually I don't know if there's ever been a Zoom chat that's broke, but usually this is around the time it does because there's just a million yeses in there. So we're really glad you guys got value out of it. Obviously, Robin, every time she speaks, I learn a lot. I know you guys do as well. And so, yeah, like she said, the idea behind this webinar series was really to, see, what are people struggling with? What are some of the new things on the horizon? And how can we deliver this in a way that is not only informational, right, but actually actionable? And so, she mentioned this before, right? We had started working with Celtic about a year ago on building something and saying, hey, what are the biggest problems that we see from a compliance standpoint, and what can we build that would actually help people handle that a lot easier, right? And so like as you can see, we know most of the time it's not knowledge that is the gap. It's really having a system that consistently allows people to have things organized, tracked, shared among internally, externally, And so Celtic, Maureen, Christy, Robin, together with us built something that we're really excited about. And so we're going to hop into Q&A and maybe 2 or 3 minutes. We really could use your help. Obviously, these webinars are free. We want to do it to give back to the community and help you guys as leaders, and giving you as much actionable advice as you can. So, what can we ask for in return? Just as a small thank you, we really need feedback right now. That would be the thing that would help us most. So, what I'd like to do, if you guys would, take 5 minutes just as maybe a thank you to Robin, I'm going to show you guys a little bit of it, not take up too much of your time. And then we've created a little bit of a survey that is very, very short on this, as you can see. So it's just name, email, what do you like, what do you don't like, and do you think it's beneficial? So I'll put a link to that in a second. And then, of course, we know you guys are busy. We also know it's only 3 minutes of your time, so maybe we don't need a gift card, but we want to, do that as a thank you to you guys. So we're going to enter anybody that fills out the survey. You'll have a chance to win a $100 gift card. If a ton of you guys do it, which would be great, then we're just gonna buy more gift cards. So please feel free to do this. So, and then of course we'll announce the winner. We'll announce the winner, either tomorrow or maybe Monday. So I'll take a second and show you guys. Actually, I like to use this as just kind of an overview, right? So I talked a little bit about this, but our company, EpiCompliance, has been around for 8 years. We work with 500 healthcare organizations across the country that use our software. So for HIPAA security, HIPAA privacy, policies and procedure, training, and then whatever industry specific tasks there are to do, they'll use our task management system with hospitals or dentistry or chiropractor or whatever it might be. They'll have their own specific module. And then, as you see, obviously, we partnered with Maureen, who I'm sure all of you guys know, Robin, Christy, and really the rest of Celtic and their consultants. And so, what we built was what we already had and really just kind of added on the skilled nursing facility pieces. So, a lot of the task management, as you can see there, we took every single task that would be required to run a 5-star SNF, a lot of them that Robin had been going over earlier. We loaded them into our platform. We scheduled them out month by month, day by day of when they need to be done. Mapped each one of them to, okay, what F tags are associated, what critical element pathways are associated. And that way it's, what to do, when to do it, why to do it, and how to fix it before a surveyor even walks in your building, right? And that way it's all in one easy to use digital platform that you can start using in literally under 24 hours. Very, very easy process. So, no more binders, no more post-it notes, no more Excel sheets, right? Everything's all in one place, easy to share, easy to organize. And so what does that do, right? Because obviously it's great to have all of that in one place, but really that leads to, of course, higher star ratings, less deficiencies. Your patients are getting better care because things are more tracked and organized, less fines. I mean, we have people that in some of our other industries that have been fined tens of thousands or hundreds of thousands of dollars. And a lot of that could have been mitigated with just better tracking and organization of what they were doing. And of course, right, some of the other things that are hard to quantify, less stress. That's a big one. Better organization, better census, leads to higher reimbursement rates and staff retention. As you guys know, all this stuff is interconnected, right? When you're running a better organization, right? When you hire the right person or when you have the right system, right? Everything it feeds off of everything, right? And so this can really help people get going in the right direction. So I'll show you guys real quick a couple of things about it. You guys should be able to see my screen there. Type yes in the chat if you can see my screen. That would help me out before sometimes I get going a little bit too far.
We're good, Tyler. We can see you.
Okay, perfect. So when you log in, like you said, it's a very easy, easy and pleasing to look at system. This is kind of your overview. And so this is your one-stop shop for all of the different tasks that you might have. And I'll show you some of the other features as well. But for you guys, we'd be coming in here. And of course, this is just a demo version. So obviously, if this was my facility would probably be out of business, hopefully, at this point, because everything is past due. But as things get completed, right, they move from pending to completed or past due. And then we can go in there and we can click on all of our specific tasks. We can sort them by due date, sort them by category, billing integrity, skilled nursing facility specific, quality of care, things like that. We can also sort them by title. At the top here, we also can, as we were talking about, just as an example, we can type in infection control, like we were talking about earlier. We can go ahead and pull up this task. And so there's a lot of things on this page, but it's very easy to use. These are all things that you're probably doing anyways. You might just be having to sort through a binder or ask somebody else, or it's in an Excel sheet or a Post-it note, or like we said, the binder, the big book of spells. Now everything is all consolidated in one place for you. So you've got, your Appendix PP here that's got kind of, the computer manual version of everything that you need. And then what we've done is gone ahead and broken that down into, your critical element pathways, right? So you can pull this up very quickly. You can see, everything from the Department of Health and Human Services here, CMS, that are associated with this particular task. You can also pull up any sort of associated PDFs that need to be completed or that have been completed, right? So a lot of people like to print things out. I'm similar in a lot of ways. So what you can do is you can, print this out, have it filled out, and then upload it back in here so that everything is all easy to track, right? So you've got your PDF in there. And then I think one of the coolest parts really is this over here on the right? We've got what is this task, right? What are we doing? What is the procedure? How does it need to be done exactly, right? How do we know that it's been completed, right? And then also the cool part is now you're starting to understand why it's important because you've got all of your associated F tags here, right? You've got the critical element pathways like we talked about, all in one place, and that way you can go in here, type in any sort of notes. You can assign this to somebody else in your organization if it needs to be done by them. It will then pop up on theirs. And then, of course, when we're done, we can download this all as a nice, pretty, kind of report that will show everything that's been done. And then, of course, it will automatically move to completed or pending or whatever the next piece is, right? So those task management are incredibly important. I think that's a place where you can come in, nothing slips through the cracks. If you're the DON or the administrator and you're dealing with this, God forbid you take a vacation or have some time off. We don't want things to fall through the cracks, and that's why it's very easy for everything is in there. All of your notes are in there. All of your paperwork and documentation are in there. How to do it is in there. And so we try to make that as easy as possible so that whether you're doing it, passing it off to somebody, or somebody's taking over in your absence, right? Everything is easy to take care of. Now we've also got, training, right? All of your training is in there. You guys know training. Don't need to really explain that one, but that's in there as well. All of your forms and policies, right? OSHA, HIPAA, security, HIPAA privacy. And then, of course, one of my favorite parts of the system is we call it the Compliant Incidents Tracking Center, but really what this can effectively serve as is a sort of a QAPI, right? And so when we go in here, again, yours would have multiple, but we've got one in here just to show as an example. So you'd be able to very easily come in here, fill out all of the information that you need as far as workplace, the who, what, when, where, and why of what happened. You can attach a supporting documentation, right? Like here, we'll be able to pull up, whatever was, attached to this page. That way we can go through and again, fill this out and re-upload it. Or if we have something else that was filled out, if you've got your own facility documentation that you want to attach, that can also be easily attached in here. And of course, as you can see, you can do interviews. You can put in, again, who was there, what was asked, what was said, and everything in there. That way it's all tracked. And then, of course, no QAPI is a QAPI without, the action that's going to need to be, taken in order to in order to improve the process or and all that. So that will be all in there as well. What is it? Who's responsible? What's the date? What's the upcoming date that is, kind of a due date, right? Or timeline for this. You can add in, new rows, resources. It will tell you, who added this, right? And everything that you need, right? And then, of course, once we're done, what you can do is you can download these reports in a very easy format. And so this will print up a nice, easy, printable, easy to look at incident report for this QAPI. And of course, yours would have much more details in here. This is just more of an example. But of course, the QAPI here you'll be able to pull up if you have 5 or 10 or however many different things that you're working on. You'll be able to pull those up. And then, of course, when it comes time for you to have your meetings for QAPI, or when it comes time to, hey, you want to share this to your DON or whatever, you can send this over to him or her. Or, a lot of times when survey comes in, the survey, instead of sorting through all this paperwork and being stressed out and, where's the binder? Where's this? Where's the DON? She's out of town. We're in deep crap or whatever it might be, right? Everything's all in there, easy to log in, easy to institute with your team. And that way you can have it all in one place, right? So that's kind of the main gist. Like you said, this is really what this is an all-in-one solution for your compliance to have everything that you need, easy to track, easy to organize. That way, less things fall through the cracks, and less Excels and binders and post-it notes and all that. That way, survey is easier, but not only just survey, right? It's really on a day-to-day basis, right? It's kind of like cramming for a test. When survey comes, well, that means you had 355 days where things were or more where things were all over the place, right? So this is really like, how do we run this in an easy, stress-free environment to where it wouldn't really matter when we got a surveyor come in, right? Because we would be ready because we've got everything ready to go. So that is the a little bit about the system. So for you guys, like I said, what we would really, really appreciate from you guys, if you would just fill this out, you can scan this QR code. I'll also put this in the chat. If you want to go ahead and just click that right now in the chat, Robin and I would really appreciate it if I can find the chat. And of course, at the end, we'll open up the floor here in a second for questions for Robin. If you have questions about this too, we would welcome those as well. I know some of you guys might be on your lunch break or whatnot, but if you could go ahead and click that, somebody besides Robin, because she's the only one that's responding to me so far, could somebody else click that link or a few guys and let me know, does that work? Because that would be, for me, this is all my previous answers I did as a test. So we've got a couple of yes and Susan not working for Susan. So Susan, I'm not sure. It might be something on your end, but if not, I can write down your name and make sure that you get it. But yeah, if you guys could all click that, the QR code, thank you. Catherine Costello as well. Yeah, I would maybe try it again. It looks like for some of you guys, and I'll have your names from the chat later. So what I can do, and I should have your emails. So worst case scenario, what I can do for you guys is find your name associated with your email you signed up with. I should be able to figure it out, and I can send it to you guys. But yeah, if you want to, for whatever you guys did, Shauna or Shanna, I will do that. What you guys should do is click that link that I put in the chat. If that doesn't work, try scanning the QR code on your phone. So here's just an example of what it looks like. It's just, what do you see as the beneficial parts? Of course, there's the task management, there's the QAPI, there's training and policies and procedures, and then having everything else. Now, if you think there's something else, we would just love to know. Robin and I would love to know what it is that you see beneficial. So the more you put in there, the more we'd appreciate it. I'd love to know what you guys are using now for all these things, because obviously, a lot of times people, when it comes to systems, they're like, well, I don't know if I want to try this new thing, right? And I always say it's kind of like the horse and the car, right? It's like you're already traveling. You're already doing this anyways. It's just, do you want to do it on a horse or do you want to do it faster, right? Now there's horse people and there's car people. And maybe admittedly we're both a little bit of both, but that's the idea, right? We're already doing task management to some degree. It just might be an Excel sheet, or it might be on a piece of paper, or it might be in a binder, right? We're already doing QWOPI, but it might just be a little bit more erratic, right? So um, I'd love to know what you're currently doing. And then from here, how much of an improvement do you feel like this might be, right? And again, we just want your honest feedback because what we're going to do with this is say, hey, what do we need to improve? We already had a lot of people that have reached out, that have gotten going, that loved it. And so if you guys, want to book time, of course, to just go ahead and see it kind of in action. I'd be more than happy to show it to you guys. But really, all we care about is just this, um, all the feedback, right? That helps us really move and be able to, just improve the product because this is made for you guys, right? This is made for administrators, DONs, DORs, and everybody in between, MDS, right? Everybody from the top down. And so we want to make sure that this is what you guys want. Now, obviously, we kind of cheated when we built it because we had Robin and we had Maureen and we had Christy, right? And so we were able to have people that have that on the floor experience, right? So looks like a lot of people have completed. Yeah, if you guys have completed, feel free to throw that in the chat. I appreciate that. Alicia, Tina, Adrian, Lee, Heather, Daniela, would really appreciate that if you guys throw that in there, and then we'll hop into Q&A. I do want to give you guys a link. Some of you guys might say, "Hey, you know what? Like, I love it. I'd love to learn more. I think that could help our facility. If you feel like it could help your facility, we'd love, to meet with you guys and show you a little more in depth. I know everybody's kind of like, well, what about my specific situation, which is true. And so obviously the best way to do that would be into just kind of like a demonstration. So if you guys, would like to set that up or you want to send it to your team or your leadership or whatever it might be, that link I just put in the chat for you as well. So, I'd be more than happy to show it to you guys. And again, it's just like we love learning from you guys because every conversation that we have, we learn more about what we need to do on our end. Because again, at the end of the day, this is all to serve you guys and make your life easier. And if it doesn't accomplish that, then then what's the point, right? So, Heather, thank you. Lee, thank you. Linda, thank you. Perfect. So we'll go ahead and hop into Q&A here.